welcome back to RRR2 YouTube series, where we are helping you to master the questions and answering techniques as well. Today, I am going to deal with the huge module Maternal Medicine. I have tried covering a couple of questions and which are commonly asked, and some of them are a little tricky. Let's go on. And so just to start with, remember, motivation is not possible always because during the exams, the stress factor invariably comes into the picture. But if you are disciplined, always you're going to do your best. So wishing you all the best for your upcoming exams. Let's kickstart. Let's start with the single best answer. Definitely, as I said yesterday, it's always a good idea to go for the cover test. So let's read the last line of the last line of the question, which mentions about what is the most appropriate management for this particular patient. Let's see what is there in here. 36-year-old second gravida presents at 36 weeks with a history of recurrent genital herpes. As this is a new guideline, expect more questions from here. She has not been on suppressive therapy. Examination reveals vesicle on her vulva. Pregnancy has otherwise been uncomplicated. What is the most appropriate management? Unlike before, remember, active lesions means it has to be a cesarean section, and the suppressive therapy is, unlike before, it starts at 32 weeks. So probably, if at all, if she's going for a delivery, then it should be cesarean section because on visible lesions. Let's see what is there. So if you could see, there are a lot of things: treat the active episodes, plan elective CS, start suppressive, and continue until delivery, plan for vaginal delivery, delay treatment, prescribe antibiotics. Yes, most of them are correct, but the best option will always be A. So yes, suppressive therapy should be started from 32 weeks. That's why I'm not going for option B. Rest of the options are obviously not correct. So please go through the current guideline, which mentions about the change in the suppressive time of the gestation period, as well as if active lesions, you should always be thinking of which way to go. And this is a quick summary, which mentions about what to do, how. So there's a genital herpes guideline, which mentions about what to be done. For example, antiviral treatments during pregnancy. Obviously, whether it is primary or recurrent, you are going to treat 5 days, and suppressive therapy starts from 32. This is the biggest change which you need to be remembering, because you want to reduce the viral shedding at delivery. That is the main thing. And management in delivery, within 6 weeks, obviously there is no change cesarean section. Recurrent HSV vaginal delivery is safe, provided there are no active lesions and membranes are intact. Okay, so remember these things. If there are no active lesions, go for vaginal delivery. If active lesions, consider cesarean section. Okay, so hopefully that summarizes the thing. Let's move to the next one. Okay, the next one, what is the most likely diagnosis? So I need to think of, as I'm reading the scenario, I'm going to work for diagnosis. 28-year-old Gravida 1 presents at 37 and history of preeclampsia diagnosed at 34. Okay, she has been on labetalol with well-controlled blood pressure. She arrives at hospital complaining of sudden onset of shortness of breath, fatigue, and chest tightness. On examination, saturation is 90% on room air, respiratory rate is 26, bilateral pitting edema. Auscultation of the chest reveals crackles at the lung bases. Heart sounds are normal. What is the most likely diagnosis? So there are two things which will come into my mind. The first and foremost thing is probably because it is preeclampsia, I would always think of pulmonary edema. The next thing is pulmonary embolism. Of course, there could be pneumonia. There could be a lot of respiratory causes, but because there is no fever, I'm not thinking of that. Embolisms, as I said, option C and D are more important. ARDS could be the cause, but they have to give you much more specific one. So here I would want to consider pulmonary edema, because there is nothing which is suggestive of pulmonary embolism. Definitely, one thing is there is so the saturation is less, and as well as tachypnea. However, to say this, I need to have probably more features to think of severe dyspnea or probably tenderness or the swelling in the one leg. Because it is not there, I would want to consider the more common one, and I would want more risk factors to think of pulmonary embolism. Pulmonary edema is one of the common complications. So that is the reason my answer, especially with preeclampsia, which could be the best cause in this case. So that's the reason I go for pulmonary edema, not for pulmonary embolism. And crackles, the crepitations, which is very typical. Obviously, if they had given pink frothy sputum, my diagnosis would be much more easier. Hope this is clear. The next one. Okay, yesterday, if you had seen my post-op module, I was trying to tell sometimes they ask you the dosage. So that's the reason I put this. So what is the immediate treatment? 29-year-old woman collapses 12 hours postpartum, found unconscious in the hospital, history of methadone use for her opioid dependence. Examination pupils are pinpoint, breathing is shallow, respiratory rate is 6 beats per minute, blood pressure is okay, pulse rate is 54. So I'm looking at opioid overdose. Obviously, I know naloxone is the answer, but unless I know the dose, this could be difficult because everything has got naloxone. So the correct answer would be 0.4 milligram IM. So there are a lot of dosages which are given, but wherever you don't have an IV access. So there are, first thing is, let's decide about the route, whether it is IM or IV. When somebody is unconscious and you have to give it quick, I think IM would be the best choice. So that rules out actually only two options will remain, B and E. When you come to the E, because naloxone 1 milligram is a little higher side, even if you don't know much of the thing, remember it is always less than 0.5 milligrams, so you will always be safe. So ideally, they would give you 0.04 to 2 milligram or 0.4 to 0.2 to 0.4. So it's always less than 0.5. So even if you don't know, you can take a wild guess and make it answer B. Okay, hope this is clear. Obviously, if she doesn't respond, you have to keep on repeating every 2 to 3 minutes. Okay, that's a factual one. Okay, what is the most appropriate next step in the management? Here I'm dealing with a second gravid with epilepsy. Guys, epilepsy is one of a very important contributor for maternal mortality. Read epilepsy well. It's well controlled on lamotrigine, okay, monotherapy. So I know the equation of lamotrigine and the pregnancies, so monitoring of the levels. So that comes into the picture first. She's on 150 milligram twice daily, presence at 32, after experiencing a generalized tonic-clonic seizure. She reports adherence to her medication and no other new symptoms, okay? On examination, vital stable and fetal heart rate monitoring is reassuring. What is the most appropriate step? So here, somebody is on a lamotrigine monotherapy where she's taking it correctly. So then you have to search for the option which talks about probably increasing the dose or measuring the levels. Obviously, so the best one could be check lamotrigine levels and adjust the dose if necessary. See, clinical judgment is good if at all, if you can do that, but it is a very subjective one. So obviously, as we know that lamotrigine levels, they are known to fall significantly in pregnancy because of the hepatic metabolism, especially in the third trimester, which is corresponding to the woman in question. So that's the reason monitoring of serum lamotrigine levels are recommended in pregnancy. So that's why you have to check and you have to increase the dose in lamotrigine. With respect to pregnancy, please read epilepsy thoroughly. Hope we are doing good. Let's move on to the next. Okay, what is the most appropriate next step in management? I think this is again the chickenpox. Please remember there is a new update in 2024 regarding immunoglobulin versus acyclovir. So go back and read that as well. Let's see. 38-year-old, second gravid at 38 weeks, reporting close contact with her 6-year-old nephew who has been diagnosed with chickenpox. Sometimes the questions could be based on the incubation period. So please make sure that you understand chickenpox very, very well. What is the incubation period and whether she needs any prophylaxis or not. Here, they haven't given. So I assume that she's at risk. She has no history of chickenpox or vaccination against varicella, currently asymptomatic. Blood test confirms she is negative. That means IgG negative. That means she's susceptible. What is the most appropriate next step in management? Obviously, if you are thinking of the older guideline, the answer should be varicella zoster immunoglobulin. However, because of the change in the current guideline, the best answer would be A, because they are now preferring acyclovir over varicella zoster immunoglobulin as a post-exposure prophylaxis. This is very, very important, guys. So expect the questions from this and read the guideline thoroughly. Okay, this is purely because of not because of unavailability of varicella zoster immunoglobulin. This has come into the picture. Acyclovir is readily available. So that's why you go for acyclovir. If you haven't read the guideline, please go back and read the guideline. The next one, okay, some values I can see. What is the most likely diagnosis? A 34-year-old, second gravida, 34 weeks, severe right upper quadrant pain, okay, something related to the liver, nausea, and malaise. She has a history of gestational hypertension diagnosed at 30 weeks, okay, which was being managed with levotalol. On examination, her blood pressure is 160/100. She has mild bilateral pitting edema. Investigations, platelets 85, which is low, AST 155, ALT 120, LDH. So I can see that there is a low platelet with elevated liver enzymes with hypertension. So my obvious with right upper quadrant pain, probably due to stretching of the liver capsule. So definitely my diagnosis would point towards HELLP syndrome. Do I have that option? Yes, I do have. Do I have anything related with the liver? Acute liver AFLP, it could be there, but the scenario is not like this, and they have to think, give me the blood sugar levels. Intrahepatic doesn't come into the thing. Viral hepatitis, they have to be giving me the whole of the LFTs with the viral profile. So severe preeclampsia, yes, it could be the cause why it has caused HELLP syndrome. So the best one would be 100% it would be HELLP syndrome. As you can see, ASTs are elevated, ALTs are elevated, LDH is elevated, platelets is reduced. So obviously I'm looking in terms of HELLP syndrome. Guys, you need to know the normal values, which for LFTs, RFTs, and the normal full blood count. So you cannot say that this is something which you were expecting for the college to give. So as I said, profound hypoglycemia, which is very common in acute fatty liver of pregnancy. This is quite a simple one. I don't think you should be doing any errors here. Let's move on. What is the most appropriate next step in her management? 30-year-old, 30 weeks, chronic cough, weight loss, night sweats, okay, hemoptysis. She has no prior history of tuberculosis treatment. Just X-ray with appropriate shielding reveals bilateral upper lobe cavitations and sputum microscopy confirms AFB is acid-fast bacilli. So I'm dealing with a tuberculosis. So tuberculosis in pregnancy. So what is the most appropriate next step in management? Obviously, it should be starting of anti-tuberculosis treatment. Let's see whether they want me to talk about the doses, duration, or if there is anything else. Okay, so looks like they want me to talk about the treatment. The first one talks about 4-drug regimen 2, followed by NHRMP for 4 months with pyridoxine. The second one, 4 and 6, which is not correct. Third one, 2 and 4. Again, that is not correct. Fourth one, monitor and delay treatment until delivery. No. Initiate corticosteroids. No. So obviously, my best answer would be option A, right? Because obviously, I would always think of giving intensified treatment for 2 months, followed by I would want to go for 4 months. When it comes to the treatments C option, what is the difference between two? Actually, here they have given 3 drugs, if you could see, right? So don't only run for the duration, always look for the drugs as well. INH, rifampicin, pyrazinamide, and ethambutol. This is a very, very, I think, important treatment which all of us needs to be aware. So that's the reason these are safe during pregnancy and no proven teratogenic effects. And pyridoxine is necessary with INH to prevent the neurotoxicity, the shock and glow disease, like neuropathy. If you want to prevent, definitely early treatment is the key. And remember, this is the talk of 2023. So please go through them thoroughly, like tuberculosis or cardiovascular, because they are important. Hope this is clear. Okay, I think I have first-line antihypertensive treatment. 32-year-old Afro-Caribbean woman. So AC inhibitors are ruled out for me because they don't work well with them. Gravidated with history of mild asthma, so labetalol I can't give. Presence at 24 weeks gestation with blood pressure readings consistently with 155/95, no proteinuria. Her asthma symptoms are well controlled. So what would you want to give? Methyl-lupin, nifedipine, labetalol, propranolol, and enalapril. So I think the best answer could be you could negotiate between two things, methyl-lupin and nifedipine. So yes, calcium channel blockers are definitely safer in Afro-Caribbean women, and methyl-lupin does also a good job, and there is no contraindication. However, if at all, if you are thinking of out of the two, calcium channel blockers are seen to be better because of their ethnicity. So you could go for nifedipine. If it is a postpartum, there is no doubt nifedipine is the choice because methyl-lupin is contraindicated in postpartum. So this could be a confusion whenever you're solving the question. So look and then answer. Okay. Okay. What is the most appropriate next step? So I have a lady who is 28 weeks with flu-like symptoms, fever, red maculopapular rash. Okay, could be any viral fever, began her face and spread on her trunk and extremities. She has not received MMR, recent contact with a child diagnosed with measles. So we might be looking at a lady who has been diagnosed with measles now. What is the most appropriate next step? For any other viral fever, because this doesn't have a specific ones like chickenpox and herpes, we do not have much of a treatment properly. Conservative could be the best one. Let's see. Supportive care, paracetamol hydration, broad spectrum antibiotics, steroids, isolation, refer to specialist. Yes, the best answer could be this conservative one, which is nothing but paracetamol and the hydration. Of course, you could do the MMR vaccine, but not during pregnancy. That would be only during postpartum, which you can think of. Supportive care is the best one for the measles. Hope this is clear, and this is a very simple and a straightforward question. Nowadays, there's a lot of questions which they ask on infections. I think I have a EMQ as well. Okay. What is the most appropriate advice regarding her postnatal diabetes? So the principle is very simple. If somebody is a type 1 diabetes on insulin, if you have increased the dose, reduce the dose postpartum. If somebody was on oral medications, you have started on insulin, stop the insulin and get back to the oral medication, because hypoglycemia tend to be more dangerous than hyperglycemia. So let's see what does this question wants us to answer. 29-year with gestational diabetes, well controlled on insulin. Okay, she delivers a healthy baby at 38, plans to exclusively breastfeed. What is the most appropriate advice? So if at all, because this is DDM, I would say probably the best thing would be to stop insulin and go back to metformin. So let's see if I have that. Yes, I have option B, sulfonylureas for glycemic control, avoid all medications. This is not done, if at all, if she was started with insulin. That means to say it is required and start oral contraceptive, that you cannot be paternalistic thinking only that would work. So that's why the best option would be B. Okay. So basically, when you go for the oral hypoglycemics also, you need to be very careful of the drug which you choose. So like sulfonylureas, we are probably you need to be, if at all, if she's on metformin, you could continue with that rather than going for the next group of drugs. Okay, hope this is clear. Fantastic. Let's start with EMQs. The EMQs, as I always say that EMQs are the killers. And here, obviously, I wanted to choose something which are tricky, like the maternal collapse, even though it's a combination of antenatal care, it could be post-op care and maternal medicine. So I thought, let me give an overall view of this, because this has been frequently asked from lots of you. So lead-in statement talks about most appropriate management. Obviously, you have all sorts of emergency medication. Let's read the scenario. 29-year-old woman at 30 weeks collapses suddenly at home and is brought to the hospital. On arrival, resuscitative measures are started. Emergency CS performed to deliver the baby. Post-delivery, she remains hypotensive despite all of this. Her heart rate is 135. That means to say there is a tachycardia, blood pressure, there is a hypotension. She appears pale with cold and clammy skin and weak 3D peripheral pulse, indicating poor perfusion. Saturation is low, 92%, while her respiratory rate is elevated. Pulmonary congestion, bilateral basal crepitations are noted on chest auscultation, consistent with pulmonary edema. JBP is raised. Confused, drowsy, suggestive of hypoperfusion of the brain beside echocardiography, reveals reduced ejection fraction of 25%, dilated ventricle, and akinetic anterior wall. So we are dealing with somebody who is perimartum CS is done, and she's still not recovering, and there is tachycardia, hypotension, and there is there is myocardial contractility is reduced and akinetic anterior wall. In this, the best drug, obviously you can tell about adenosine, adrenaline, noradrenaline. Please remember, already all these things are done, and when there is a tachycardia with, we want to improve the myocardial contractility, plus you want to take care of pulmonary congestion, the best drug would be always dobutamine. Dobutamine is the first drug line of agent in cardiogenic shock, especially when there is a lot of tachycardia with a poor ejection fraction. Adenosine and all, you know that you will use in SVT. Adrenaline, you don't want to use when there is a tachycardia. So the best choice here is dobutamine. Obviously, you have to give a lot of drugs, but if one drug they ask me to select, I would go for dobutamine. I have a comparison for when to give dobutamine, when to give adrenaline in the coming slide. So remember, when there is poor cardiac output, when it is a cardiogenic shock, when there is the blood pressure is low, but it is not too low, then you will always think of going for dobutamine. Let's see the next one. 36-year-old, 16 weeks, collapses, but quickly stabilized after resuscitative measures. Echo reveals LVD with evidence of heart failure despite the cardiac findings. No signs of hemodynamic shock. There is mild tachycardia, but rest of the things seems to be stable. And there is severe dyspnea or orthopnea. Again, here the best answer could be digoxin. I'll tell you, this is very, very, very useful when you give digoxin instead of, you might think, why not dobutamine? Okay. But the problem is, dobutamine you use in cardiogenic shock. Here, if you see, dobutamine is not required because she's maintaining herself well, but there is some amount of left ventricular dysfunction which you need to correct. That's the reason you still need a drug which can actually increase the myocardial contractility, but not working on other things because they are still doing good. So that's the reason you go for digoxin, not dobutamine. Of course, if you ask me out of dobutamine and digoxin, which is the safest in pregnancy, it will always be dobutamine. Okay. So this is a justification slide where I'm going to talk about adrenaline. You will be using when there is life-threatening bradycardia, profound hypertension where the blood pressure is, systolic blood pressure is less than 70, and there is a severe cardiac arrest. When dobutamine you use with cardiogenic shock with tachycardia, and whenever you have this like profound hypertension, tachycardia, then you could always think of dobutamine. If not, you can think of adrenaline. So it is just the scenario based, but understand how the drug works. And we'll do a few more and I'll show you the comparison. 29-year-old woman at 30 weeks collapses dome, brought to the hospital. Unarrival resuscitative measures are initiated, fluid resuscitation and vasopressors. There is no significant tachycardia. Blood pressure is critically low. Oxygen saturation is 90%. JBP raised. Skin appears calm, pale and clammy. She is drowsy and confused. Now tell me, what is the drug of choice? This must be an easy guess. As we have been discussing, whenever there is a severe hypotension with no significant tachycardia, you always think of adrenaline as the first one because systolic blood pressure shoots up faster because there is a vasoconstriction with adrenaline, which helps peripheral vasoconstriction, which helps to increase the systolic blood pressure. Hope this is adding on to your already whatever you have got the concepts about these drugs. So basically what I'm trying to tell you, where to use adrenaline, where to use dobutamine. Okay. always have the heart. I'm not going to the mechanism of action because that is not something which you need to be thinking of. But remember, adrenaline is an inotrope and vasopressor. Basically, it causes severe vasoconstriction. That's also one of the reasons why you don't want to use it when there is a tachycardia. But here, it actually basically works on myocardial contractility and heart rate consideration. When there is tachycardia, if you push adrenaline, it is going to worsen. So that's the reason you might want to use the other drugs, not this one, okay? And where is the clinical example where you use when there is severe hypotension, systolic hypotension, where you want to increase it quick, use adrenaline. But if there is pulmonary congestion, where do you want to increase the cardiac contractility with not so severe profound hypotension, no tachycardia, you can use dopamine. Both of them cause tachycardia, but it is worse with adrenaline. That's the reason you choose dopamine instead of adrenaline in tachycardia. When you come to dopamine and dopamine, as I was trying to mention you, so basically, whenever you think of renal hypoperfusion, okay, so you might use dopamine. Otherwise, whenever there is acute heart failure with the blood pressure being preserved, you go for dopamine. So basically, when the preference in pregnancy will always be dopamine, as I was mentioning, not the dopamine. These are additional information. Just remember the basics, what I explained. I think that would be able to help you to do better. Okay, so I know cardiac drugs could be a little confusing, but hold on to the concepts. And if they ask the first drug, you have to look into the scenario, whether myocardial contractility is affected, whether there is pulmonary congestion, whether there is tachycardia, how severe the hypertension. If you work on these 4 elements, I don't think it's a big deal to answer them. This is one of the questions I think they had asked in the last years, which talks about, because you get a lot of women on insulin pumps now, right? Or probably somebody who is on insulin doses. So you need to know how to manage them, right? So this EMQ is all about appropriate insulin adjustment. Let's see, obviously you have got all sorts of things here. 28-year-old pregnant woman, type 1, insulin dependent, on insulin pump, reports consistent post-meal hyperglycemia. Her fasting blood glucose levels are within target. She denies hypoglycemia. So there is absolutely no problem except post-meal spike. So what do you do? Whether you increase pre-meal, whether you increase post-meal, whether you decrease, whether you increase both, or whether you add a basal insulin. So the best answer would be only increase post-meal insulin, because in pregnancy physiologically also there is always postprandial hyperglycemia due to hormones like HPL. So it is just required because she is not having hypoglycemia fasting levels, because fasting levels are very well controlled. So just adjust this rather than changing a lot of things. This is as simple as that. I think I have one more question based on this. Okay, a 30-year-old with type 1 diabetes on multiple daily injections. She is not on insulin pump. She has elevated fasting glucose levels, but normal post-meal. So she denies any episodes of hypoglycemia. Here the thing is, postprandial is well controlled, but fasting is the problem. So that means to say, we need to work on her long-acting basal insulin dose, because those are the ones which should be giving as the actual good control of fasting. Please remember, if it is a postprandial hyperglycemia, then the morning dose is to be corrected. But if it is fasting hyperglycemia, then you need to think of long-acting or the night dose to be calculated and corrected. Okay, so hope this is helpful, because there were 2 questions and people keep asking me about the same. That's the reason I thought this could add on to the value. Perfect, guys. Okay, so this looks like about the GBS. Again, one of the very common one. 32-year-old men, 39, presents with pre-labor rupture of membranes lasting 20 hours. GBS status is unknown. So the answer should be whether to give IAP or not, whether you give yes or no. But there are 2 things which I'm seeing, because obviously I can see IAP only to be given administer penicillin as first line. There are a lot of options which are correct here. IAP if more than 18 hours, IAP if more than 24 hours, and offer if only IAP. Because there is 20 hours, and I know prolonged PPROM, you are supposed to be giving IAP, so I would choose option of I. Definitely that should be correct, but my point is they could give you one more option which talks about less than 18 hours just to confuse you. Because if in hurry, if I don't see this, I could go for this. So please read the scenario, even if you know it well, sometimes you can miss on the most important things. So read the scenario carefully. Next one. 30-year-old woman presents at 38 in active labor, vaginal swab tested for GBS colonization. So I don't think there should be any confusion here. Obviously, you should offer IAP, so that there is no confusion there. And penicillin is obviously the first choice because they haven't given me the allergies. The next one, GBS UTI at 36 weeks. So obviously you will treat now and give the IAP. So I don't think so there is any confusion there. Treat now and offer IAP. Okay, however, so there is one more option which could be confusing, just to draw your attention here. Okay, so R and option C. Okay, if you could see, C says treat now and then offer IAP. This says offer oral antibiotics for GBS UT and plan IAP. What is the difference? Why not R is correct? Why C is correct? Because C specifically mentioned you have to treat it now and offer IAP. But here, what they say is you can offer antibiotics. It is up to her to take or not, and you can plan IAP. So that is the difference between the vocabularies. You have to treat it now and offer IAP is the most appropriate rather than thinking offer oral antibiotics for GBS. It could be specific, but you're only offering, you're not going to treat her. You say her, okay, if you wish, you can take, and you will be thinking of planning IAP. But so understand the difference between the vocabularies. This is most appropriate rather than R. This is just to draw your attention for the different vocabularies, what you can have, right? And this column is very, 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 very important. So remember, whenever you have a preterm labor, offer IAP, previous infant with GBS, invasive GBS, offer term, you don't need to give if there is purely pre-labor rupture, except for if there is a prolonged rupture, as well as if they have a maternal sepsis. Okay, let's move on. Diagnosis. As I said, the infection is the one which could be the killer. Let's see. I have to come to the diagnosis before I see the options. I always read the scenario and then come to the conclusion and then go for the options. 29-year-old Asian woman, okay, 31 weeks, third trimester, signs of premature labor, okay. Reported 3 to 4 weeks history of visual disturbances, zigzag lines and flashes, weight loss, fever, night sweats, episodes of hemoptysis. It revealed tachypnea, hypoxia, diffuse fine crepitations, diffuse micronodular infiltrative pattern with calcified nodules, which is nothing but very, very clear diagnosis of tuberculosis. Please remember, whenever you get, especially from the endemic areas like Asian and losing weight, night sweats with calcified nodules, you should always think of tuberculosis, which is a granulomatous infection, okay, which has affected even the eyes here. So you need to be careful, and they respond very, very well with the starting of anti-tubercular treatment. Next one. Flu-like symptoms. 2 days later, she presented with fever, itchy red spots with complex spots. So I don't think I need to further on, as we are all aware, complex spots are nothing but measles. Please remember, it is rubeola, not rubella. So be very careful when you mark. Complex spots are very, very typical. Remember, conservative treatment, supportive treatment is the key. Okay, the next one. 34-year-old asylum seeker, antenatal care at 36 weeks, delivers vaginally at 29. Okay. Postnatally, the baby is SDA, microphthalmia, congenital cataract, okay, pulmonary artery stenosis, the rubella triad, which you need to be thinking in. So this is congenital rubella syndrome. So please know these rashes. They could give you for the baby after it moves from cephalic to caudal and it starts being The rash starts behind the ear, so you need to know about the typical features, how it goes, because they could give you dengue, they could give you Zika virus, so know the infections well. The next one, fever, myalgia, flu-like symptoms at a 32-week. Her antenatal tests are unremarkable. Recalls eating unpasteurized cheese 2 days before the symptoms onset. We do know that unpasteurized always comes from listeriosis. Of course, they could give you brain lesions, stick lesions, who has a lot of pets at home. Think of toxoplasmosis. So, make sure that you guys go ahead and read the infections. I would also suggest you to read about the COVID and the recent HMPV infection breakdown as well, because this is brand new, not for the exam sake, at least you should know, because that is something which is a recent breakdown for the knowledge sake. Okay. The next one, fever, malaise, maculopapular rash, slap cheek. So parvovirus. Please know with the parvovirus when and how frequently monitor and what is the percentages for IUFT, MCA, PSP after how many weeks you will be monitoring, because it's very, very important to understand fetal ascites, fetal pericardial effusion, and how you are going to treat, because it won't stop here. Okay. So guys, I think I've done more than 10 EMQs purely to give you a feeling of what it is. Of course, there are lots and lots of topics like cardiac disease as such, VT prophylaxis as such. There are a lot of infections which I haven't touched on, and asthma, the respiratory diseases, which except for few, I haven't touched on a lot of things. GIT, IBDs, you know, the drugs you need to know. CNS system, like multiple sclerosis drugs, you need to know. Maternal medicine is a huge module. However, what I want to say is, whatever the question they give you, understand the concept, understand the question, treat the question in front of you, then you would always go correct, and try eliminating options and read the options carefully. Look for similar type of options which will help you to do well. Okay, hope this session is useful. Don't forget to drop your feedback. Don't forget to drop the messages like if you have any doubts, and don't forget to subscribe and share to your friends. All the best. May success be yours. Don't forget to watch the rest of the RRR series, because it's purely for you to understand the question pattern and to get the approach. All the best, guys. Thank you so much for watching. Thank you.